Good afternoon, everyone. Welcome to Google Healthcare's 360 panelist discussion. We're excited to host three world-class CIOs and CTOs who will illuminate us today on trends and areas that are hurdles in the new normal in healthcare. My name is Dr. Esteban Lopez. I'm the market lead at Google Cloud's Healthcare and Life Sciences practice. I'm a practicing physician board certified in both internal medicine and pediatrics. And I'm excited to talk to folks today that are going to talk to us about the patient experience and expectations that are going to be evolving even faster in healthcare and the competitive landscape that's to come. So let's get started right away with our panelists, starting first with Andrew Troy. Andrew, why don't you introduce yourself?
Absolutely. Thanks, Esteban. Thank you, Google, for inviting me today. My name is Andrew Toy. I am the President and Chief Technology Officer of Clover Health. Clover is a dedicated Medicare Advantage payer, so we look after seniors and the disabled. And our mission is to improve every life. And the way we look to do that is by investing in data-driven, personalized primary care, so that we see our approach bringing great benefits to all seniors on Medicare, making it easy for any physician to use technology to deliver that data-driven primary care. And when that happens, we believe that everyone wins, right? Patients win, physicians win, and society wins by having more efficient healthcare. So really delighted to be here.
Thanks, Andrew. And let's move on to Neil Stein.
Hi, Neil Stein from Ortho Carolina. We're an orthopedic group that serves the Carolinas. We're based out of Charlotte. Our focus as we go forward is on the patient. So how do we drive better outcomes, better support, as well as understanding what our providers need in this organization to actually provide those items. We are also looking at innovative ways to use our data to actually drive the future of medicine, as well as understanding how the clinic of the future will operate.
Great, thanks. And last but not least, Brett Trefla.
Good afternoon. It's a pleasure to be here. Thank you, Google, for inviting me. I'm Brett Trelfa, Senior Vice President and CIO for Arkansas Blue Cross Blue Shield. We're looking for opportunities to partner with the tech titans to help us solve really interesting problems using big data and helping bring digital experiences that are personalized to our members. So some of the things that we focus on are ultimately helping people achieve their best health outcomes by navigating the healthcare system with a little less friction. So that's our focus, and we're really looking forward to this conversation today. Thank you so much.
Well, thank you, guys. We're really excited to have you here today. So let's just go ahead and jump in. There has been a digital revolution that has disrupted so many other sectors, and healthcare is no exception. And so as healthcare execs are ramping up for the transformative tech of the future that will reshape patient care, what are your companies doing around that? Why don't we start, Brett, with you?
Well, we've got our foot in a lot of different doors. So we are experiencing a really high demand for what we would call in our industry telemedicine, really referred to as virtual care in other circles. So we see that trend will continue. And so some of the things that we think about are related to that is how can we bring data to our providers and exchange information efficiently so that we can preserve context. And so we apply that to our customer service experiences, thinking about leveraging voice channels and being able to bring personalized experiences to people in the way they prefer to communicate, whether that be chatbot, voice, a mobile app, or a web app. We want to preserve the context and understand where they started in their journey with us in terms of whether it's looking for information around helping them navigate a healthcare scenario, or it might just be getting connected to a doctor, or it might be answering a question around a bill. So we want to remove traditional sources of friction and make that easy for people to navigate. I think you also can look at the fact that big data cannot be understated in terms of what we can do with it. We are uniquely positioned with claims data that no other entity has on behalf of our members, which allows us to predict health outcomes And we would like to share that information not only with our members, but with their providers when consent is granted. So we're looking for ways to facilitate that kind of exchange of next best action that are, clinically relevant next best actions. So lots we could talk about. We could take that in a bunch of different directions, but that's sort of a highlight of what we're focusing on.
Andrew, how about you at Clover? What are you guys doing in that space?
Yeah, absolutely. So I want to plus one some of the stuff that Brett said just then. There's a reason, as many people might know, I actually was at Google prior to coming over to Clover. And one of the reasons why I am a payer now is exactly what Brett just said. Because we have access to the claim stream here, it's very possible for us to longitudinally follow members and patients no matter where they get care. So if you think about when you go to the doctor, as long as you stay within that health system, the EHR can track you and can aggregate your data. But if you move between health systems, which I think is what Brett was alluding to here, well, you get lost, right? Like, how often do you go in there and you're like, well, I better repeat to this doctor everything I've told to the previous doctor. You go to another doctor, I better repeat to them everything that they say to that, and then scale that over caregivers. It's crazy, right? We have to keep our own medical history and information in our head, or maybe for our care, for people we love, track them too, so we can educate the physician so they can do the best job. So as a payer, one of the things we can do is actually get that information, then share it out to the physicians so they can have it at their fingertips. They can focus on what they do best, which is use that information to deliver care. And we have a platform called the Clover Assistant that does that. But that's one of the really powerful things that payers can do, is get more involved in that sort of data aggregation and sharing, because it's very difficult to do from the physician side.
Neil, well, talk to us from the provider standpoint. How do you react to that?
So Brett and Andrew are spot on. As we go forward, it's understanding where that data is. From the provider perspective, who actually owns that data? Right now, it's siloed off. And there are some people who think the patient owns that data. But then how do they manage it, as Andrew pointed out? How do we make it in a position that it's free, that we can, and not free as a monetary, but set free so we can use it for patients? The other aspect is driving patient access and defining what that actually really means. So how do we get the provider and the patient together without all these other hurdles? And this is where cloud providers are helping, right? How do we manage things as we go through them to actually drive the notion of your data is available to when you need it, and it's also controlled and secure. So as we go forward, we want to make sure that the payers, providers, and the patients all have a control around the data, but are allowed to actually get that data out so we can actually have good intelligence around that information.
Well, then let me ask you a follow-up on that, Neil. As a CIO, tell me what you need from the tech industry to help you achieve those goals. What are some of the things or solutions that you're looking for?
So there's a notion of FHIR, which is a great connectivity type of tool set. So as we go forward, how do we get the standards that we actually really need? And how do we actually get the canonical format of that data? So there's a notion of a data lake, there's a data reservoir, but until you actually know what the data is moving back and forth, how do you manage that? Last thing the tech industry can actually help us is, if you go back many years around DRM, right? So how do you actually tag that data so I can set it free for my physicians to go see? If I need real payment data, how do I get that through my provider organization? So the tech industry can help centralize that and get to a real standard around how we're actually sharing the data. Last part is no matter how big your healthcare organization is, you will never have the capabilities that a Google could have around data center type of resources. So how do we make sure that the data is always available? If there's a slowdown to that data transmission, if there's an inability to get there, that creates problems within the clinics. So we want always available, designed to fail type of thought process around the infrastructure components. And this is where organizations like Google and other cloud providers can help us.
So what I'm hearing is data harmonization and creating a standard around clinical data or device data. Great. Any other reactions? What else does the industry need? Either Brett or Andrew.
Yeah, I would love to jump in. So first of all, fully agree. Like we believe in FHIR very strongly. We base all our technologies on it. And I think what Neil was also alluding to is also true, which is we all know that standards are the way of the future. Healthcare is a little slow in moving towards that. There's a lot of gravity that the major tech players can bring in, like Google, to say, "No, this is the standard. This is what you should use." As people move to the cloud, make it easy to lift and shift into the cloud, into those standards, right? And that way, automatically, you just get them for free almost. I think is really powerful. The second thing, I'm just going to do a shout out here that particularly I think Google can help with. And Brett, I don't know whether you have this challenge. I'm guessing you do, but it is a nightmare as a plan to aggregate all the information at the provider level. I don't know, provider data is just a nightmare problem that we have. And so, I happen to have Neil on this stream, so I could say, "Hey, Neil, can you just shoot me over all your addresses and your rendering providers and all the information and where are they practicing?" And maybe, Neil, you'd be like, "Oh, sure, Andrew, I'll help you out. I'll shoot that over." But we have to do that over the entire network, which is just crazy. And all of this is standard data that every provider has to give to every plan, right? And it's nothing specific. It's just who's at which facility, where is that facility, is it open, is it accepting new patients, right? And I have a whole team just gathering this information. I bet you Brett has a team gathering this information and putting it in. It's crazy that we have to all do this. And it would be very logical to me that a tech company would aggregate that data for us and make it available, keep it clean, keep it rich, organize data, make it available. Just to allude to which company I'm talking to here, would be very logical to help us out in that regard.
Yeah, right. Provider directories. I mean, I came from Blue Cross, so I understand those can be very challenging.
Yeah, that's a really good point. There isn't a payer in the United States that doesn't have a team of people chasing that data.
Everyone just goes to Google Maps to get that data, right? Like looked it up there. We could make that easier. Yeah, it's crazy how many resources go in there.
Well, I think you guys have made some really great points, and I would like to add that I think the way that companies like Google could help us is thinking about how we can more easily orchestrate interactions without it really being thought of as the payer doing that. In other words, how could we bring like scheduling services into provider practices and connect our members? Maybe we could envision a day where we have even bot-to-bot communications taking place between payers and providers, scheduling appointments on behalf of our members so that we take friction points out of the system. Any of us that have tried to schedule an appointment with our doctor, especially during the COVID period here, it is really encountering some access to care challenges. You're months out sometimes with some of these specialists. So what we'd like to be able to do is really help with the prioritization of these appointments. And when we see somebody that really needs help, we're getting that call. How can we facilitate that? And it's difficult. Today it translates into another phone call to a provider practice. And all these phone calls going into the provider aren't helping them see more patients, even with their front staff, because their front staff's trying to manage the medical records, the intake. It's a very difficult challenge for them. So I think we've got to find ways to ease the burden of doing those basic things for our provider practices so that our members have a better experience. So I would add that to the thought process as well.
Right. And I want to add one item, Esteban, before we move on. It's not just the medical data. So notoriously, clinics run behind. And a lot of times it's because patients arrive late. And so looking at data beyond that, so, how do tools such as Waze come into it, where everybody gets notified, you have an appointment tomorrow at 1. But it wouldn't be great if you got notified, hey, listen, you need to leave now. There's traffic on 95. So you can go this route this way, so you're on time. So the people behind you aren't delayed. And it's notorious people want their first appointment in the morning or the first appointment right after lunch because they have schedules. So as we go forward, how do we use data? So theoretically, you can have an appointment Monday afternoon. You show up and we see you when you show up. So balancing out people's lives as well is key to the future of medicine, because we know how busy everybody is and how complicated things are becoming.
Yeah, no, great point.
To that point, just to add to it, because now you've got my brain flowing a little bit, even scheduling the transportation for the person, if you could coordinate that for people who have transportation needs. there are a lot of people in our society that just don't make the appointment because they have difficulty getting there to begin with. So if we could bridge those gaps and identify them, that would be pretty phenomenal.
Well, now we're entering that health equity, social determinants of health space. And so talk to me a little bit about how your organizations are addressing that, or how you think technology or data would be useful to be able to address that.
Yeah, this is really near and dear to my heart, obviously having come into healthcare to work on specifically this. I think there's two dimensions the way that I think about it, the way Clover thinks about it, is that number one is that, from a mission perspective, obviously we want to bring great care to everyone in the country, right? Everyone on Medicare. That makes a lot of sense because we want to help people no matter which, neighborhood you live in. Do you live in an area that's close to your doctor, far from your doctor? What demographic you come from? Whether you're in rural areas, which I know is near and dear to a lot of our hearts. We need to serve all of these people. The other dimension is from building a great business, that greatly increases our addressable market, right? So wearing my mission hat, it makes a ton of sense. Wearing my sort of business hat, it lets us bring more people into our plan versus taking a very narrow approach, which I think a lot of Medicare Advantage plans do, and drawing circles around certain neighborhoods or demographics or geographies. So we have a big emphasis. And one way we think about health equity, which I think is a little bit different than a lot of other payers, is to say, hey, we want to be able to serve any doctor, right? Rather than having a narrow network HMO, we focus on PPO and broad network. And then let's arm the doctors in that network with software that raises the standard versus the other way around, which is, why don't we look at all the providers, and then pull in network the ones that are already high performing. I think we already don't have enough doctors in the country. We need to make arm doctors and make them all great, give them superpowers, right? And that's the approach we need to take in order to serve the largest number of people in the country, is to take that physician-centric approach, figure out who's giving care, let people choose their own doctors, and then arm doctors with superpowers via technology.
So data as a superpower, I love it.
Yeah, absolutely.
And maybe to add to that, connectivity as a superpower. So we talked about this before, that just some of our patients we find in rural settings don't have the proper connectivity to take advantage of virtual care scenarios. So they end up having to get into cars and go to a brick and mortar location where they could have probably handled that through a virtual care solution. So I'm optimistic that eventually we will get 5G everywhere, or at least have closer proximity to these areas where we can engage more people. There's all kinds of ways we can do that. We could bring buses and things like that into communities, but ultimately we need to unlock the communities and give them access to the connectivity so they can take advantage of virtual care scenarios. And then the payers are thinking about, well, how do we transition? Because this is the technology is forcing us to rethink how we pay a claim on a virtual care visit versus an in-office visit. So, at our organization, we're treating them the same. In fact, we're encouraging people to leverage these capabilities, especially given the pandemic. It is something that I think we will see more of, and it's here to stay. It doesn't mean to say that brick and mortar will be replaced entirely. That's not possible. But it is. I do think there's a really strong case that many of our needs can be satisfied through virtual care services. And so to Andrew's point, if we have the data provided to these virtual care physicians, PAs, whomever's engaging, that just enriches the whole experience and gives a better patient outcome.
Yep. And one last piece to bring into is looking at the overhead. So not only looking at the data, but are there capabilities out in the cloud to leverage the sheer compute power? And when I look at overhead, can we actually manage the resources required? So there's just a certain amount of time in the day. There's just a certain amount of resources to actually help patients. Well, we can optimize that time and optimize those resources based on looking through the data, as well as computing and quickly saying, we don't need 5 people in this clinic. We only need 2. So now we can actually have more locations with the same number of individuals without overtaxing them. And the goal there is to actually optimize access for our patients. So yes, we want a provider-focused environment, but we want to really take into account the patient. Patient access is the key to the future. And that is needing to free up the providers, as well understanding how we code and everything with the payment process, so they aren't taking a hit and they're actually feeling empowered to actually see more patients or see a certain number of demographics that they haven't seen before.
So creating operational efficiencies that result in better access because you have more ability to open more sites. I love that. So there was mention of the pandemic. We can't talk about technology. We can't talk about healthcare without mentioning the pandemic that we're currently still in. So talk to me a little bit about what the pandemic has taught you, and what would you have done differently if you knew the pandemic was going to happen?
I think it's very interesting. There's been so many different phases of the pandemic. I'm sure everyone's thinking about that as well. I'm trying to rewind all the way back to the very beginning as we first felt about it. There's a couple different things that I think that we look at there. One is we've already discussed, as we discussed, the movement to virtual, right? That was a big deal. I mean, now it feels like a little bit like, oh, of course we should have done that, and that's correct. But that was a big deal. All of us, I'm sure, worked on it on this call, and that was a tremendous achievement by the healthcare industry to move on to virtual. And we just need to not lose that momentum. And I think what we see is there are parallels to that in the way that we work. If you look at the future of work dynamic, right? Every single one of us, I think, I'm not quite sure, but I think many of us are at home. I'm at home. That's the one I think you are as well. But you can see this push and pull even in thinking about how employees return to work. I think we as a society are grappling with where this needs to go. But to me, it's very clear, right? We are going to become a distributed society, and things will become more distributed. I'm not using the word remote. Remote implies that you are either with the center or you are remote from the center. And I think that's the wrong way to look at it, right? We want distributed care, not remote care. We want distributed workers, not remote workers, right? And so when we distribute and decentralize these things, what we do is increase access to them, because without centralization creates a bias on the population you can serve because of geographic proximity, which I think something both Brett and Neil have alluded to, right? If people who live closer to a high-performing medical center will get better care than people who do not live close to a high-performing medical center. That is not equitable. That is not reasonable. What we need to do is be able to use technology to spread that over, just in the same way if you're very talented but you don't live in Mountain View, perhaps you should be able to work for a high-performing tech company, right? These are all things that are true in our society. It is clear and apparent to me that is the direction we will go in. But there will be some turbulence in the next few years as I think leaders sort this out in their own heads.
Yeah, I love that concept of remote versus distributed. That's the first time I heard that. So thank you for that.
And to add a little bit to that, we also need to look at, I think Brett brought it up, about ensuring that certain populations have access. So where tech giants can help out is bandwidth, right? So our standard bandwidth in the United States for broadband is a joke, right? So how do we get the federal government to say it needs to be 50 or 100 megabits both directions, right? So that's one big thing. And then helping, these technologies get out to everybody. So we talked about telehealth or virtual health, and one piece that to me as we moved to the pandemic was left out is ease of use. Tools aren't as easy as people expect them to be, right? So you get a provider sitting down, you're going to do telehealth right now. Okay, that time for them to set that up should be one click. They need to spend 5 minutes setting it up. That's a waste of time. So how do we streamline that entire process? This is where tech giants can come in and say, okay, here's our standards. Here's how you actually connect online, right? So people went to certain tools because they were really easy. But then we found security holes in them. So without pointing any, how do we actually help our, and work with a tech industry to say, hey, this is what we really need. This is what security means as we go forward. And here's how we need to make sure it works with not only 10-year-olds now, 20-year-olds and 70-year-olds. It needs to work the same. What's nuance? And we need to get past that idea of, these things are for everybody. Last part we need to be real careful about as we go to telehealth or virtual health is swinging the pendulum too far, right? Certain practices, you need to be with the patient. You need to be close to the patient. So can you do that through technology? Can you get actually facial recognition saying, yeah, this patient may not be in as little pain as they're telling you. They're actually in more anguish than they're letting you believe. But you can't get that through a two-dimensional screen. So as we go forward, where does that pendulum sit? And how do we make sure that both the provider and the patient are getting what they need so the patient has a better outcome?
Well, you guys are really impressive responses. You covered a lot of what I might have covered. I think the one thing I would emphasize is that the pandemic has probably produced one good thing, in at least in context of our company and probably many others, which is a strong realization, and I'll use Andrew's word now because that's a great word, that this idea of a distributed workforce outside of your state boundaries can be accomplished. And so when we think about acquiring talent, we're thinking about it totally differently than we used to be just very transparent with you. We are now looking at talent across the country. So when we do that and we can allow people to work where they can best work, we're getting the best and the brightest minds thinking about solving these problems, and that's how we can really collaborate the most effectively. So I get really energized about that point. We still need human contact, all of us do, but this allowance for being a distributed workforce, distributed healthcare, is something I wish we would have realized earlier. And I'll just echo Neil's points. The connectivity thing, we witness it every day. Every day we witness the concerns around that. So where our tech giants can help us with our politicians, I think we all need to come together on this point and build out the appropriate infrastructure for our future country. The future of our country is at stake, really, with respect to it.
So let's pivot now for a second. So COVID taught us that convenience plays a powerful role in healthcare as well, especially for patients and providers. How do you imagine the theme of convenience and consumerism in healthcare continue to play out? Brett, why don't we start with you? You finished the last statement.
Well, I think we kind of touched on a number of these points, but I think where it's appropriate, I always tell people this really interesting story of how I experienced consumerism and focusing on the patient's needs. In this case, it was my son. We were on a sailing trip. We were on Lake Michigan, and he developed a really bad ear infection. We contacted our primary care physician via phone and said, we've got a problem here. He has a history of chronic ear infections, so we knew that, she knew that. And we were trying to figure out where can we get to be able to help him. And do you have a recommendation of what port of call we should go to, that kind of thing. We were thinking about the logistics behind this. Long story short, she helped orchestrate for us. She knew a doctor in Michigan. She helped orchestrate the prescription being written in Michigan. We figured out where we needed to get to in terms of a close port. And then we contacted the marina, and they were able to, on our behalf, go pick up the prescription because we didn't have ground transportation, and meet us at the marina with it. And I just thought to myself, wow, if we could bring those kinds of experiences together in digital ways and in other ways through the ecosystem to coordinate the Uber for transportation, or one of our docs for a virtual care situation like we were facing, how powerful can that be for bringing convenience and peace of mind to know that you're going to get the care you need when you need it? And so that's an experience I tend to share with people. It's one of many. I'm sure others have many experiences just around how do you simplify. We talked about this earlier, making the appointments with your doctors or getting access to refills. There's follow-up sometimes involved with the prescriptions that we issue or prescribe to people. So if you have to come back for that follow-up and your doctor forgot to schedule that appointment, could we facilitate that in some way? Could we predict that that's needed? There's all kinds of little things. I think it's going to be these little incremental actions that we take collectively that are going to generate the big transformation.
Yeah, along those lines is also looking at the patient information, right? So to make it simple and seamless, once I entered it, I should be able to share it. Why am I re-entering the same information over and over again? And to Brett's point, what the pandemic has taught us is people want that convenience, but normally they may go across state lines to go see the doctor they're in a clinic, let's say in North Carolina. Well, if they live in South Carolina and they dial in or virtual presence in, where is the patient being seen? How is that managed? So as we go forward, how do we actually look at boundaries a little bit differently? And how can our partners in the tech industry help us understand that certain boundaries need to be flexible? And how do we drive that notion as we go forward that we're balancing all those pieces out? So, Brett, beautiful example. Sorry to hear about your son, but as we go forward, how do we bring the country together to be able to leverage all the wonderful providers we do have? We have a treasure trove of incredible surgeons and primary care doctors in every discipline. But how do we gain access to them across the entire country? How do we provide high resolution conferencing? If you're on a soccer field, how do you actually talk to your doctor real quickly? But it's not a low res 320. You're looking at 1080 and other things. So how do you actually have those conversations as you go forward to bring our healthcare community closer and closer together?
Hey, Neil, if I could jump on that, you triggered a thought around, and that community of physicians and PAs, et cetera, have so much insight from the work that they do. There's this question too of how do we tap into that knowledge base, if you will, to generate even better insights and outcomes. So an example of a conversation I was having earlier today with one of our physicians was a recognition that there's a pattern developing in a certain part of our state. And in that state, there's a recognition that most of the people work in the chicken industry. And we're looking at what's the correlation between them working in the chicken industry and having these chronic health conditions with the kids coming in to see their doctors. And so a correlation was made. I won't get into all of that, but we would have never even thought about that had we not had some physicians say, we think there's something going on here. A correlation between the work they're doing with chickens and the dander associated with it and the health outcomes that they're seeing. So it's just very interesting to think about if we could tap into that greater knowledge base, how wonderful would that be? And how could we find solutions?
And that's the panacea of population health, right? We're keeping people healthy before they become a chronic issue to themselves as well as society. So, yep.
Yeah, I mean, I just want to strongly affirm, like, completely agree with the convenience here is access to care. And I think there's two phases that the way we think about it is phase number one, like what I believe is the best user interface. I took to my team, the best user interface to our members and patients is the primary care physician, right? Like we want to make the primary care physician the interface to the patient because they are the best equipped to quarterback care, make decisions, and honestly influence the actual patient to take the action. Esteban, you must have experience here. Like everyone wants health, but not everyone necessarily wants to do the things that will make them healthy. Those are two very different things, right? And so number one is who will be most convincing? What's the best way to convince folks to take the right action? The primary care physician. So let's equip them with those superpowers to make the best decisions. And then the second aspect of convenience, which I think was brought up very well here with many examples, once that primary care physician makes recommendations to the patient, how do we make it incredibly convenient for them to fulfill those actions, right? And so if they're like, hey, you need to take this med, as Brett said, maybe that Brett needs to be delivered to the marina, right? Like, because otherwise you won't get it or you'll take some other kind of action. So one is, what does the physician want? Number two, how do we then make it super easy for the patient to fulfill what was recommended by that PCP? Because to be clear, many, many things are not convenient right now, right? We all know that. They're like, oh yeah, I know, but it's so expensive, or it has weird side effect. I don't like taking it, or it's inconvenient to get to the pharmacy, or I don't want to finger stick. You know, that's all these reasons that make sense to the individual that we need to make it convenient and easy for them to fulfill.
You know, it used to be that the healthcare system was designed around the physician and the physician's convenience. I would argue as a practicing physician that the healthcare system is not designed around my convenience, but it's definitely not designed around the patient's convenience. It's designed around the system's convenience, right? So how do we start doing design thinking where we start designing around the patient? We do have to bring the provider at the center with the patient, because if you're not designing around both, the provider can often sabotage your best efforts because she has the power of the pen or the order. So how do we reimagine healthcare in a way that is designed for patients at the center, and honoring the fact that our doctors and nurses have to be part of that design as well?
As a payer, we're concerned with providing financial protection for our members, but as well as helping employer groups, in the case of an employer group, manage cost. But ultimately, we do really want people to achieve their best health and maintain that best health, because we actually think that's ultimately the way you get after the cost side. So the question of how do we bridge this gap that you're asking about, something we're exploring, and other companies have explored this as well, as how do we draw closer to the provider community through value-based arrangements. So these value-based agreements are enabling us to think differently about data exchange, to bring that design thinking with the patient at the center. And what we're finding is we're actually more successful with the large hospital systems that have the financial resources to do that than we are with the smaller ones. So I think we start there, we test the model, we see if we can get it going, and then try to replicate that pattern across the ecosystem. That's one area of investment for us. And frankly, we actually have a really good relationship with our provider community. We have to. We're contracting with them. We're wanting to reduce friction on the provider side as much as we are on the member side. So we learn from each other around what's working. And I think that collectively, we're going to get to that question, the answer to your question, which is how do we get the patient at the center of this? And I think those hospital systems that can help us with that will be leaders, and then we'll be able to establish the pattern and move forward.
Yep. And along those lines also, it's evaluating something that's decades old is fee for service, and helping build out based on data and real analytics that actually prove the trajectory that alternate models do work and may be more efficient for both the provider and the patient, as well as minimizing risk to the payer community. So as we go forward, how do we leverage big data and the compute behind it to actually show that a proven means to an end, fee for service, can actually be uplifted and moved to the next wave? And then along with that is helping the cultural shift where people need to feel comfortable based on the data, understanding that both the payers, providers, and then also the patients will have better outcomes across the board and maintain what they've been working for all their lives. So that's the key piece too that I look at. As for the change, all three groups need to work collectively together.
So what I'm hearing you say there is aligning incentives, right? That the incentives are misaligned right now.
Yes.
Yeah.
I completely agree. I mean, we should probably almost have a whole session. I'm trying to keep my tech hat on here, but I violently agree with you, Neil, where just if we can switch to just health wonkiness for a second, right? The dynamic between fee-for-service and value-based care was raised by both Neil and Brett just here. And I could not agree more that is the existential problem that we have right now, right? Larger systems are able to move to value-based contracts, just like Brett said. That makes a ton of sense. And there's some dynamics that are weird there, but those can be fixed. But we're leaving behind a ton of these smaller providers too, who are not able to move to downside risk or even maybe shared savings. And how do we move them, right? Otherwise, you're going to create this two-party system, right? Two-class system with some folks on fee-for-service, some folks on value-based care, and it's going to be tracked. I think technology actually has a role there to create a simpler incentive line, like you said, Esteban, but that, where we use a technology platform to try and smooth that out a bit. But that alignment of incentives and payment is a huge, huge problem that we need to crack the nut on.
So I'm gonna pivot for a second. We know that there's going to be both a physician shortage and a nursing shortage, especially by 2030, based on the growth of our population and the number of docs and nurses that are coming out of their training. How do you see in the future things like AI, algorithms, apps further driving not only predictive analytics, but data-driven clinical decision-making? How do you see that working either within your organizations or within healthcare, period?
So my view on it is, looking at the whole life cycle of the patient and how do we keep them healthy longer, right? So if we have shortage of resources to support them, we need to manage that piece out. So it's always looking at technology where it's benefiting the patient, and it's helping the provider treat that patient. So just imagine wearables. You have your wearables and that data is uploaded to your doctor. So when they come in, they've had time to actually review that you've been truly exercising and what you're doing. They see what your heart rate is. They see other pieces. They see changes in your gait. They see changes in just your overall dietary patterns. And they can help you stay on the plan. We all do things that probably aren't healthy for ourselves. So how do we manage those? We all age, unfortunately. So as we grow, how do we get that knowledge into the patient's hand coming from a trusted person, their provider? On the other side is, once again, managing the overall risk, giving those incentives for people to be healthy and make it simple, right? A lot of organizations have programs for well-being, walk 3 miles a day and all these other items. But when you look at your daily life, how do you actually do some of these things? You just have too many burdens that you need to work through. So helping the patient stay healthier longer is key as we diminish other resources. The last part is looking at why are these resources diminishing? How do we actually create a better life balance for our provider community while they're in the clinics? What's missing? Can the tech industry help us be more efficient in there so they're not burnt out at the end of the day? And it is a field that people still want to go into at all levels.
Yeah, I completely agree. The way I think about it, just for me from an engineering standpoint, would be, first of all, I think we'll be totally fine. That'll be the controversial statement that I'll put forward. I think we'll be totally fine, but only if we make certain changes, and those changes are totally doable. And those changes come back to incentives again, but the key KPI we need to be fine is that for every physician, every clinician, so we include the RNs, the MAs, anyone in the clinical side, the KPI is simply what percentage of time are you performing work that is top of license? That is the only KPI we need. And I bet, and this is, I think, completely consistent with what you're saying, Neil. I think we're saying in a slightly different way. So much work right now is done where you would self-identify that as a clinician that you are below license, that there's massive amounts of inefficiency in the ecosystem, right? So we can do this. This is not a zero-sum game. We can take it all out of the inefficiency if the physician is at top of license and that cascades down so that their RN is top of license and that cascades down so the MA is top of license down to the front desk, they're top of license. That's like 1,000% efficiency probably that you've gotten out of the system. That's where tech comes in, right? Is to make sure that KPI stays high.
Yep, couldn't agree more.
I haven't studied this problem too closely, but I could imagine that there are clinicians outside of the United States that would be willing to render virtual care, to our citizens if we could figure out those arrangements. And so that would be enabled through technology, obviously. We know that there's robotics that are coming into play in the operating rooms. And so those are opportunities for, people from remote control scenarios managing those instruments. But I would think that incentives will be a big thing, and as well as just trying to figure out what the supply and demand curves are going to look like. One of the things that we see in our state is encouragement from our state officials of reaching into the schools and talking to students about you should consider becoming a nurse or a doctor or a physician. So that's encouraging to see. But at the end of the day, I think it's going to boil down to, do people see value in being in that field versus, let's say, being a programmer where you can work at Google? Some of the financial incentives for people who could be a doctor, they look at it and they say, I could be in another field of discipline that also interests me and I could maybe make more money sooner. The educational requirement to become a physician is pretty onerous. So I think maybe we need to look at some of those factors, but a lot of that will be questioning regulations and licensure. So in order for us to achieve that, but that's my 2 cents. I think we're all kind of wrestling with that particular problem, but in another way, we're also wrestling with shortages in technology, access to technology resources that understand big data, that understand really digital experiences, understand cloud integration. It's really hard to find those resources in our country right now as well, and they're getting top dollar. So it's kind of interesting that we're finding a resource shortage in many ways in many areas.
So, but with that said, though, healthcare is not known to be a fast mover in technology. The fax machine is still here because of healthcare, right? In Germany, the number one buyer of fax machines are healthcare entities. In my practice, I clearly have a fax machine, and all of that data is coming in on an image. And about 80% of the healthcare data is still unorganized or unstructured. When I write a note and I free text it, that's all unstructured data. So how do we then move forward in healthcare to be able to, one, get rid of fax machines? And I would assume that even with our payer colleagues, I came from a payer, we were getting virtual faxes. Humans were reading that. A nurse was reading it to make a determination on a prior authorization. And that nurse was reading scanned EMR pages, right? And then if he or she could not approve it, it would go to a physician, where then she would then do the exact same work that nurse was doing to either approve or deny that care, and bumping it against certain criteria. That's a very manual process. How do we move forward to start automating that with existing technologies?
Well, there are rules-based engines that we've been working on to help with that. Like, I think you're describing some of the prior authorization kind of processes that exist in companies. And then there's also this concept of chart chasing that you brought forward, and whether that's coming across on a fax or you're actually getting physical paper that you then scan. We use, OCR, natural language processing techniques, to be able to bring that into context. Truly, it's only about a 70% success rate on the scanning, and then you still have to have a human look at the 30%. So it is a big challenge for us, but you're hitting on something that's really important, because if you could eliminate the source of what I call the analog data that you could easily digitize on a tablet, we really leapfrog into then being able to exchange and share data much more efficiently. We understand that scans and things like that are likely to be areas where AI can come into play, and maybe we can train the AI to identify the cancers on the radiological scans and those kinds of things, and that'll help with throughput for our physicians in those particular disciplines. So I think technology is going to find its way into all kinds of areas in that way. One of the things at another competing pair where I used to work that we did was actually use NLP extensively to put the scans into context, so that we could then use those electronic health records with our predictive analytics engines. And so it took a tremendous amount of effort, but it was very rewarding and worthwhile, especially for our senior population where we're trying to close gaps in care. So I think there's some good news out there that you're right. There's some existing technology where we can do this. I don't know, though, if somebody could give me the answer to this. I don't know when physicians are going to finally get out of the practice of needing a physical health insurance identification card. We have phones that have these displayed. We don't need a card. And if you just think about that, how silly is that to talk about? It costs, though, a lot of money into the system. There's an expense associated with producing these cards. They cost anywhere from $5 to $25 to produce. And every time you go and see your doctor, they want to see the physical card. It's not necessary. We could exchange that through a mobile app very easily. And it's those kinds of interactions that we should enable and cut out the waste associated with producing these cards.
So, yeah, I agree with Brett. The airline industry did it a long time ago, right? You don't need to have a ticket. You can use your wallet on your phone. But as we go forward, some of the key things is that it needs to be available. And Esteban, as we go back, it also goes back to standards. So the tech industry can help healthcare with creating true standards. And these standards need to be extensible. So, you have XML, JSON. Well, what's better? Well, if you can extend it and ignore things you don't care about and only pull the data you need out of that standard, that's great. This way, you have one common theme to things. So as you go forward, I believe the tech industry can help healthcare understand, here's your standards as you go forward. Here's what they mean. Here's how you use them for interoperability. And point out where you could actually be efficient. So once again, minimizing risk. health industry wants to minimize risk. So as Brett pointed out, if we can get away from those insurance cards that we need to now have $1,000 scanner to scan that thing in, and we're saving an image into our EMR, what a waste. If we can get rid of the scanners along with the fax systems, that makes great sense. E-prescribing has come a long way. So the health industry has moved, but look at who's on the other end of e-prescribing, the pharmacies. They want efficiency. So if you look at things that stay within healthcare, healthcare is on both ends. So how do we help both ends in healthcare want to be efficient, from large and small, from financially sound to financially shaky? They both need to have the same opportunity to the technology. And this is where tech giants can help out, level the playing field, help all organizations get to the next level and be where they need to be.
So I'll also add here, I'll start to ratchet up trying to say some controversial stuff for fun. But what I would also say is that the problem with healthcare is that the best practices of technology in healthcare are wrong. I would say they're more common wisdom than best practices. And so when we build software for physicians, and when we built the Clover Assistant, we launched that in mid-2018. I don't want this to be an advertisement for Clover, but I'll just talk about our experience. We're building a care tool for primary care physicians to use that will deliver our data to primary care physicians. That's what Clover Assistant is. And I did about the usual thing. I talked to CIOs, I talked to CTOs, I talked to all the healthcare folks, and they said, Andrew, to get adoption, it's going to have to be on-prem. No, don't touch this cloud thing. Integrate it with the EHRs. Build it into all these systems. Build it into Epic. Do all these things. And then I said, well, what's an example of a great app that's launched following these best practices? And they were like, oh, no, I don't have an example. These are just the things you should do, though, and then it'll work, right? And I'm like, well, what's the best engagement you've gotten when you've launched this way? Oh, we get about 10 to 15% engagement, NPS of like 5, right? And I'm like, okay, well, let's not try that then, right? So in 2018, what we did, and that's what I would encourage more people to do it this way, launched an all cloud-based application, no on-prem availability, no EHR integration to start, separate pane of glass, completely focused on the needs of the clinician and clinical information, no corruption by this is how you bill. Physicians hate anything to do with this is how you bill, right? They're forced to do that, not given that. If you do all those things, none of which are controversial to us as technologists, right? We have gotten to incredible NPS, 90% engagement rates. Over 60% of our population goes to a Clover Assistant doctor now. The problem is all the common wisdom of healthcare IT tells you not to do those things, right? And that's crazy to me. We need to actually follow the best practices of the tech industry and figure out how to match it to healthcare, not be constrained by the other way around. So that's what I would also say.
I love that. So you talked about being on-prem or versus the cloud. That brings to mind security, cyber attacks, ransomware, where patients feeling very concerned about their data being secure. How are you managing these threats or security, and how are you looking to your cloud provider to help you deal with security and threats?
Yeah, I mean, I'm obviously very cloud favorable, so I'll go first so people can give a more bearish view if they want to. I mean, the cloud is clearly the future, right? I mean, I came from Google. There are people who have concerns about the cloud, but the key again here is to have the bravery to move ourselves forward and, of course, address security, address privacy, follow the best practices, segment data, do all of those good things, but be clear that none of those things require on-prem, and none of those things are precluded by the cloud, right? Like, that's just really clear. Like, the first principles are all right. The mistake is saying, well, cloud is hard to do that. That's not true, right? Like, a lot of us keep our personal data already in the cloud. If you use a bank, you have your financial data and money in the cloud. Let's be clear, that's already up there at this point. So I think there is that dynamic that people are concerned about, rightfully so, but I think we are getting past that point now where people feel like on-prem is the only way those things can be delivered. In fact, I believe it is actually far more secure, more private if you are in the cloud than if you are on-prem at this point.
Yeah, so I agree with Andrew, as well as, To me, I think Louis Pasteur had a saying, luck prepares, favors the prepared mind. And as you go out to the cloud, understanding what you're getting into, I'm not saying it's more or less secure. We've all seen it where people inadvertently leave a default password out there. And that's where the prepared mind comes in. And so to me, as we go forward, how we manage things, as we move out to a higher compute platform out in the cloud, like GCP, we look at things around educating the team, educating the resources who are actively looking at those systems, as well as putting processes in place where there's checks and balances. It's always key not to leave things up to a single point of human failure, not the technology component. Technology may break and may have problems, but as we go forward, it's the human failure that tends to let these big cyber attacks get through. We're going to have the small ones. Don't worry about the small ones. We'll trap those, manage those. So as we go forward and start using cloud technologies, we want to ensure we're educating our team members, making sure they understand what our cloud providers are providing, and more importantly, what they can't provide. Where is that line that they don't cross? That's our accountability still. And as long as we assume that accountability, we will be in a good place when you move out to the cloud. It's when you think the cloud provider is doing everything. That's not what they're there for. That's not what they're going to go do. They're going to provide the services they tell you they're going to provide, and they provide them extremely well.
Yeah, you guys said that really well. The only comment I'd add to it is one of the things we educate folks around is that if you think about what the cloud brings, that you're getting more value than you are putting at risk. And that's something that people should think about. The access to capabilities that we cannot create ourselves or recreate easily, and probably shouldn't, like let's voice recognition. Why would I ever create my own voice recognition modules? I'm going to go to the cloud and access those where they're readily available, nor do I necessarily want to manage something like that on-prem. So I think that's another little point I'd offer to folks, is that we educate chronically around where cloud really provides so much ability for us to do things and to gain access to things that we just simply can't otherwise. And the scalability of it too is a big thing that we used to talk a lot about, but actually that's one of the most powerful components of it, being able to tear environments up, or stand them up, and tearing them down. So controlling your cost becomes a real, in today's environment, it becomes a real value add. We used to think that it was very, very expensive. It kind of was in the early days. Now it's kind of reached an economy that makes sense.
Well, I think we have one more minute left. I'm going to give each one of you one last closing thought, and we're going to wrap up. So, Andrew, why don't you start first?
Yeah, I think that what I would just say is there's reason to be optimistic. I'm a very optimistic person, right? Like there's so much room in healthcare for us to add low-hanging fruit, that if we can just target that low-hanging fruit, focus on it, do all the things that we talked about today, none of those are super difficult. We just need the will to do it as an industry, and things will be much, much better, honestly.
Neil?
Yeah, so it's not looking at tech industry, tech giants coming in and taking over healthcare. It's looking at them as strong partners for the future, and understanding all the work they've done is the next level of the foundation that healthcare should be built on. They're not looking to take it. They're looking to actually collaborate and drive forward on better patient outcome.
Right.
I think I'll say ditto to Neil's comments. That's along the lines of what I was thinking about. The partnership is key. And so for us, we're looking for those partners that can help us make a difference. And I think the last thought is that we'll probably get at this incrementally. If we try to do it big bang, we'll likely fail. So we need to every single day be taking incremental steps.
Well, ladies and gentlemen, thank you so much for joining us today on our Healthcare 360 panelist discussion. We've had Andrew Toy from Clover Health, Neil Stein from Ortho Carolina, and Brett Trefla from Arkansas Blue Cross and Blue Shield, talking about the future of healthcare and how technology is going to influence that. If you have any questions with regards to Healthcare 360, don't hesitate in emailing us at healthcare360@google.com. Thank you so much, and have a great rest of your day.